ഹലോ, സുരേഷിന് കേൾക്കാവോ? ഹലോ സുരേഷ്,
sir. Good evening.
കേൾക്കാവോ?
കേക്കാം. Okay, sir. Okay. ഞാൻ പറയുന്നത് കേൾക്കുന്നില്ലേ സാർ? ശരിയാ, മ്യൂട്ടാ. നമ്മുടേത് വോളിയം മാക്സിമത്തിലാണ്. മ്യൂട്ടാക്കണമെന്നില്ല. അതില് CJ ജോൺ സുദർശൻ സാറ് അവരെയൊന്ന് മ്യൂട്ട് ചെയ്യാം കേട്ടോ. പെർമിഷൻ തരണം. എനിക്ക് പെർമിഷൻ തന്നാൽ മാത്രമേ എനിക്കിവിടെ കൺട്രോൾ ചെയ്യാൻ പറ്റും. ഇത് തന്നിട്ടില്ല. മാഡം സംസാരിച്ചാൽ മതി. അപ്പൊ എനിക്ക് കുഴപ്പമില്ല. അല്ല, ജയ്സന്റെ കമ്പ്യൂട്ടർ എടുത്താൽ എനിക്കത് മതി. എനിക്കത് മതി. എനിക്ക് സംസാരിക്കാനായിട്ട് ഈ കമ്പ്യൂട്ടർ മതി. കൺട്രോളിങ് ജയ്സനായിട്ട് എടുത്തോളൂ. ചാർജ് ചെയ്യണ്ടേ ഇത്? ഞാൻ പോസ്റ്റ് ആയാലും കുഴപ്പമില്ലല്ലോ. ചിലപ്പോ ഞാനിങ്ങനെ എന്റെ കാണുന്നുണ്ടോ? അതിലും ഞാൻ സാറിന്റെ പേരിട്ടിട്ടുണ്ട്. അതുകൊണ്ട് കുഴപ്പമില്ല. ഒരു സെക്കൻഡ് കേട്ടോ, ഞാൻ അവിടെ കൂടെയുള്ളൊരു എന്റെ സിസ്റ്റർ ഹെൽപ്പർ കൊടുക്കാം. മ്യൂട്ടിയിലൊക്കെ ജയിച്ചിന് അവിടെ നിന്ന് ചെയ്യില്ലേ?
Hello, Arun Kishore.
Hello, CJ. Hello, Rashna.
Hello. How are you?
Very fine, very fine.
എങ്കിലൊക്കെ ഇരിക്കുന്ന കാര്യങ്ങളൊക്കെ.
Sudhi, Ashoka. സുഖം തന്നെ.
ഓ സുഖം. ഞാൻ ഇതിങ്ങനെ കണ്ടപ്പോ ഞാൻ ചാടി കയറിയതാ.
നന്നായത്.
At least I could see you now.
Hello, Suresh.
Sir, good evening. Good evening, sir.
Good evening, good evening. Enne kekamo call from Idiki, Dr. Sudarshan.
Hello.
കേൾക്കാം സുധി.
ഒന്ന് ഉറക്കവേ. ആരും അനങ്ങാതിരിക്കണെങ്കിലും എല്ലാരും ചിരിച്ചുകൊണ്ടിരിക്കുന്നു. ആത്മഹത്യയെ കുറിച്ച് ആലോചിച്ചിട്ടാണോന്ന് ഞാൻ ആലോചിക്കണേ.
ശരി.
രാധാകൃഷ്ണനൊക്കെ ഇങ്ങനെ നല്ല ചെറുപ്പമായിട്ടൊക്കെ ഇരിക്കുന്നു. കുറെ നാളായിട്ട് കണ്ടുകൊണ്ടിരിക്കുക.
ഞാൻ ആശുപത്രിയിലായിരുന്നു, അറിഞ്ഞായിരുന്നല്ലോ അല്ലേ?
അറിഞ്ഞു. എല്ലാ വിവരങ്ങളും കിട്ടുന്നുണ്ട് ഇവിടെ. ഓരോ പേഷ്യൻസ് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുമ്പോൾ എല്ലാ വിവരങ്ങളും പറയുന്നുണ്ട്. ഇപ്പോഴും കമലഹാസന്റെ മാതിരി തന്നെ ഇരിക്കുന്നുണ്ട് കേട്ടോ. എന്നിട്ടും കുഴപ്പമൊന്നുമില്ല. ദൈവം സഹായിച്ച്.
എന്ത് പറ്റി?
എനിക്കൊരു വിസ കിട്ടി, ടിക്കറ്റ് കിട്ടാഞ്ഞോണ്ട് തിരിച്ചു പോകുന്നതാ.
അതെ, കാലിന് പോലും വേണ്ട നാടൻ ഭാഷയിൽ അല്ലേ?
അതല്ല.
എന്താ പറ്റി?
ആണോ രാഷ്ണ? ഞാൻ വിളിക്കാട്ടോ ഇത് കഴിഞ്ഞിട്ട്.
ഹലോ,
ഞാൻ വിളിക്കാം ഇത് കഴിഞ്ഞിട്ട്.
ആയിക്കോട്ടെ. തലമുടി വളരാൻ വല്ലതും ചെയ്യുന്നുണ്ടോ സുദർശൻ? സുദർശൻ മുടി വളരാൻ വല്ലതും ചെയ്യുന്നുണ്ടോന്ന്?
മുടി വളരാൻ ഒന്നും ചെയ്യണില്ല ഭഗവാന്. ഞാനിങ്ങനെ
ഹലോ സുധീര.
എന്താണ്?
ഞാൻ അതാ വിളിച്ചോണ്ടിരുന്ന അരുൺ. അശോക ഉണ്ട് തോന്നുന്നു അല്ലേ? അശോക. ഹലോ അശോക.
പരിചയമില്ലാത്ത എല്ലാവർക്കും ഒരു ഗുഡ് ഈവനിങ് പറഞ്ഞേക്കണു കേട്ടോ. ഞാൻ ഡോക്ടർ അല്ല, അപ്പൊ ഒന്ന് ഇത് വേണ്ടേ? ഡോക്ടർ ജോസഫിനോ വരുമോ?
വരും. ഇൻ ബിറ്റ്വീൻ ജോയിൻ ചെയ്യും.
അപ്പൊ പിന്നെ എങ്ങനെ മീറ്റിംഗ്? അത് കഴിഞ്ഞിട്ടാണ് മീറ്റിംഗ് തുടങ്ങണം. അത് അരുൺ കിഷോർ സ്റ്റാർട്ട് ചെയ്തിട്ട് വേണോ നമുക്ക് മീറ്റിംഗ് തുടങ്ങാൻ? മറ്റേ ഫോർമാലിറ്റി
അല്ല, അവര് കണ്ണൂർ ഒരു മീറ്റിംഗിലാണ്. അപ്പൊ ഇൻ ബിറ്റ്വീൻ ജോയിൻ
പറഞ്ഞിരുന്നു. അതെ, എങ്ങനെ പറഞ്ഞു? അപ്പൊ
നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. ഇൻ ബിറ്റ്വീൻ അവർ ജോയിൻ ചെയ്യണമെങ്കിൽ നമുക്ക് നോക്കാം. സാർ തുടങ്ങിക്കോളൂ.
So good evening to everybody. In absence of Dr. Joseph Benavan, Dr. Shashikumar, Shashidharan, and my committee members, Dr. Suresh, Dr. CJ John, Dr. Joyce, Dr. Sagar, Dr. Sadish, Dr. Sajikumar, Dr. Varsha, invited guests like our own member, Dr. Arun Kishore, ഈ വോളണ്ടിയേഴ്സ് ഇൻ ട്രെയിനിങ്ങിന് കൺസെന്റ് തന്നിരിക്കുന്ന എല്ലാ പ്രിയപ്പെട്ട വോളണ്ടിയേഴ്സ്, പ്രിയപ്പെട്ട ഫ്രണ്ട്സ്. വർദ്ധിച്ചു വരുന്ന ഒരു മാനസിക സംഘർഷവും അതിലേക്ക് നയിക്കുന്ന അശാന്തിയുടെ സാമൂഹ്യ പശ്ചാത്തലവും തികച്ചും നമ്മയും അസ്വസ്ഥരായിക്കൊണ്ടിരിക്കുകയാണ്. നാം എല്ലാവരും ഒരു മനുഷ്യരാണ്. സമൂഹത്തിലേക്ക് തുറന്നു വച്ചിരിക്കുന്ന ഒരു മനസ്സുമായിട്ടാണ് നാം പ്രവർത്തിക്കുന്നത്. അസ്വസ്ഥതകൾ തരണം ചെയ്യാതാവുമ്പോൾ നാം തന്നെ ചിലപ്പോൾ നിരാശയുടെയും അസ്വസ്ഥതകളുടെയും പടുകുഴിയിലേക്ക് വീണ് മാനസികമായ പല സംഘർഷങ്ങളിലേക്കോ ആത്മഹത്യാ പ്രവണതകളിലേക്കോ ആത്മഹത്യകളിലേക്കോ വഴിതിരിയുക. ഇങ്ങനെ ഒരു അവസരത്തിൽ ഒരു കൈത്താങ്ങുമായിട്ടാണ് IMA ഡോക്ടർ വിനവൻ സാറിന്റെയും ഡോക്ടർ ശശിധരന്റെ ആതുരത്തിൽ നമ്മൾ എല്ലാവരും കൂടി സംഘടിച്ച് ഒരു കൈത്താങ് എന്ന മുതലെയാണ് IMA ഹെൽപ്പിംഗ് ഹാൻഡ്സ് എന്ന് പറഞ്ഞ് തുടങ്ങിയിരിക്കുന്നത്. അതിന് ആദ്യത്തെ പ്രോഗ്രാമായൊരു ട്രെയിനിങ് പ്രോഗ്രാം ഇവിടെ നമ്മൾ തുടങ്ങാൻ പോവുകയാണ്. as you know, എമിനന്റ് ആയിട്ടുള്ള എല്ലാ നല്ല ടോപ്പിക്സുകൾ എടുത്തിട്ട് നാല് പേരെയാണ് നമ്മൾ വെച്ചിരിക്കുന്നത്. യു ഓൾ നോ അരുൺ കിഷോർ എന്ന് വെച്ചാൽ നമ്മുടെ ഓൺ മെമ്പറാണ്. കൂടുതൽ വർണ്ണനകളും നിറങ്ങളൊന്നും കൊടുക്കേണ്ട. കാരണം എല്ലാ നിറങ്ങൾ ഇട്ടാലും എന്റെ ക്യാൻവാസിൽ അവനെ കുറിച്ചുള്ള നിറങ്ങൾ അപ്രാപ്തമായതുകൊണ്ട് ഞാൻ ഒന്നും പറയുന്നില്ല. അരുൺ കിഷോറിനെ ഞാൻ ഇതിലേക്ക് വെൽക്കം ചെയ്യുന്നു. ഇൻ ആബ്സെൻസ് ഡോക്ടർ ലക്ഷ്മി വിജയകുമാറുണ്ട്. സ്നേഹ ആത്മഹത്യ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ WHO എല്ലാത്തിലും വെളിപ്പെടുത്തിക്കൊണ്ടിരിക്കുന്ന ഡോക്ടർ ലക്ഷ്മി വിജയകുമാറാണ് അടുത്തതായിട്ടുള്ളത്. ദെൻ ഡോക്ടർ അനിൽകുമാർ, നമുക്ക് ഏവർക്കും അറിയാവുന്ന ഒരു ഇതാണ്. ഞാൻ ഇത്ര സ്പീഡിൽ പോകുന്ന അരുൺ കിഷോറിന് സമയം കൊടുക്കുന്നതിന് വേണ്ടിയിട്ടാണ് കേട്ടോ. ആൻഡ് ഓൾസോ നമ്മുടെ അഡ്വക്കേറ്റ് ലിറ്റോ സോയ്സണിനെ കുറിച്ച് എല്ലാ സ്റ്റഡികൾ നടത്തിക്കൊണ്ടിരിക്കുന്നത്. ഇത്രയൊക്കെയാണ് നമ്മുടെ പ്രഗത്ഭരായിട്ടുള്ള സ്പീക്കേഴ്സ് ആയിട്ട് വരുന്നത്. അപ്പൊ ഇന്ന് അരുൺ കിഷോറാണ് തുടങ്ങുന്നത്. അപ്പൊ അരുൺ കിഷോറിനെ ഞാൻ ഒരിക്കൽ കൂടി വെൽക്കം ചെയ്ത് താങ്കളെ ഏവരെയും ഇതിലേക്ക് വെൽക്കം ചെയ്ത് 100% താങ്കളുടെ അകമഴിഞ്ഞ സഹായ സഹകരണങ്ങൾ അഭ്യർത്ഥിച്ചുകൊണ്ട് ഇതൊരു പൂർണ്ണ വിജയമാക്കണമെന്നും, ഇത് മെഡിക്കൽ സ്റ്റുഡൻസിലും ഡോക്ടേഴ്സിലേക്കും ആണ് നമ്മൾ ആദ്യം വയ്ക്കുന്നത്. കുറച്ച് കഴിയുമ്പോൾ നമ്മളുടെ റേഞ്ചുകൾ എത്രത്തോളം കൂടുന്നു അതനുസരിച്ച് 8 hours 12 hours 24 hours ആയിട്ട് ഒരു കണ്ടിന്യൂസ് പ്രോഗ്രാം, ഒരു വർഷത്തെ മാത്രമല്ല ഒരു കണ്ടിന്യൂസ് ആയിട്ട് ഒരു പ്രോഗ്രാമായി മാറ്റണം. സോ IMA ഹെൽപ്പിംഗ് ഹാൻഡ്സ് ഒരു പൂർണ്ണ വിജയമാക്കുന്നതിനും താങ്കളുടെ ഏവരുടെയും സഹകരണങ്ങൾ ഒരിക്കൽ കൂടി അഭ്യർത്ഥിച്ചുകൊണ്ട് ഞാൻ അടുത്ത ലൈനിലേക്ക് നീങ്ങുന്നു. സോ നന്ദി, നമസ്കാരം. താങ്ക് യു. ജയ് IMA, ജയ് സെക്രട്ടറി.
നമ്മുടെ IMA president and secretary, they are in a meeting at Kannur. So anytime they may join. നമുക്ക് അങ്ങനെയാണെന്നുവെച്ചെങ്കിൽ can we go to the next item in the agenda?
Thank you. Oh yeah.
Okay, sir. So they may join at any time. So meanwhile, we can introduce our speaker, Arun Kishore,
Yeah.
sir. I have the great pleasure and it's a proud moment for me to introduce my own teacher, my own MBBS time teacher, Dr. Arun Kishore. In fact, he is the person who actually tempted me to choose psychiatry as a specialty. Now, Arun Kishore, sir, he is working in UK. Now we are starting our volunteer training program with our veteran speaker, Arun Kishore, sir. So he'll be enlightening us about the emotional problems in doctors and medical students. Arun Kishore has got enough experience in the field of tele-counseling and all counseling aspects for doctors and medical students. In fact, he has got background experience in group analysis, Berlin group, and also he is the coordinator of ASHA Facebook. ASHA means Accept, Support, Help Another. That is the short form of, that's a short form, ASHA. Arun Kishore will be guiding us all through our pathway in tele helpline service. He'll be providing us pastoral service and other services for improving our skills in our tele helpline service. I'm not taking much time. Before handing over the mic to Arun Kishore, sir, I will invite our Vice Chairperson, Dr. Joyce, to propose a vote of thanks for this short inaugural function. After that, we will hand over the program to our the advisor of our committee, C.J. John sir is there. So he'll be moderating and he'll be controlling the program. Before that, I will invite Dr. Joyce Gio to propose vote of thanks, and then we'll start the program.
At the outset, I take this opportunity to congratulate IMA and IPS team for initiating this wonderful initiative of preventing suicide and well-being of doctors. And let me not take much time. Sudarshan sir was taking very less time for his welcome speech, so I should be shorter than him. So let me thank you, our guest speaker, Dr. Arun Kishore. Sir was initiating, even though sir is working in UK, sir is there in Kerala and India for many of our academic programs, so supporting IPS. And last state conference, he was the guest speaker. And many Berlin group training and many of our academic program for PGs and for medical college teachers and psychiatric specialists, sir is there with us. So I take this opportunity to thank you, Dr. Arun Kishore sir, for being with us for this event. And Dr. IMA leaders are yet to come. In their absence, I like to thank IMA President, Honorable General Secretary of IMA Kerala State and other office bearers of IMA for initiating and joining with IPS for this wonderful program. And Dr. Suresh Kumar, PN Suresh Kumar sir, is the backbone of our IPS program of well-being and suicide prevention among doctors. And sir was organizing and arranging and calling all the leaders together for a physical as well as Zoom meeting for arranging this program. And today we are starting the program, this academic section. I take this opportunity to thank Dr. V. N. Suresh Kumar sir, and I can see Dr. C.J. Jones sir. No need to thank Dr. C.J. Jones sir, because sir is there in IPS. Sir is our father, early figure in IPS, for helping us for our all organizational and academic matters. I welcome Dr. C.J. John. And Sudarshan sir is there along with the youngsters. And even if we need a fatherly figure, sir is playing a role model for all of us, playing several roles. Thank you, sir. And Radhakrishnan sir is there. I can see your face, sir. I take this opportunity, sir, for initiating many public programs along with IPS and in the field of rehabilitation of psychiatric patients. And thank you, sir, for being with inaugural function and the academic session of today. And being it's a Zoom, many faces I can see, and many faces are not much. So many leaders. I think more than 80, around 90 people are attending. I think people are yet to come for this Zoom meeting and Zoom session, academic section. And let me thank all the delegates and doctors, psychiatrists, and other non-psychiatric IMA colleagues and other trainees and medical students, PGs, for attending this program. Thank you all. Thank you.
Thank you. Now the mic is handed over to Dr. C.J. John for the further procedures. Thank you.
Dr. Benavin is around.
was also the past president of IPS Kerala.
Dr. Benavin is around. Dr. Benavin.
Okay.
You
Dr.
can do the
Binavan,
form.
welcome, Dr. Binavan.
Yeah. Dr. Sudarshan, Dr. John, Dr. Suresh, and all the other friends. As we all know, this committee, that is Committee for Emotional Well-being and Suicide Prevention, is one of our prime committees for this year. And it has been formed with a definite goal and objective. That is to try to put an end or try to find a solution to the increasing number of suicides and stress-related issues among medicos and doctors. So we've been working hard. This committee has been working hard for the past 2-3 months. And now we're slowly coming into the implementation stage. And I'm very happy that they have put together this. We've got Dr. Arun today, who will be taking us through the various sessions. And in this regard, I would also like to thank and congratulate the Indian Society of Psychiatrists for joining hands with the Indian Medical Association on this noble venture. So once again, I thank you for this great effort and thank each one of you who committed and dedicated to this cause. So let's hope we'll make a difference to our doctors and students. So thank you so much and best wishes.
Thank you.
And also,
Okay.
we'll be launching the app. The app will be called IMA Helping Hands. We've not made a formal announcement on that. The helpline that we are developing will be named as IMA Helping Hands. We are working on the app also so that it becomes very convenient. The privacy of the caller is also maintained. So that's it. So it's my honor and privilege to announce the name IMA Helping Hands. And thank you all for being working hard on this. Thank you and best wishes.
Thank you, sir. Thank you, sir.
Thank you. State Secretary is around. Dr. Shashi.
No, we are all in a meeting. I just jumped out of the meeting. I suddenly remembered that.
Okay. So without wasting much time, we'll go to Dr. Arun Kishore, because this is a quasi-training sort of session, and as he presents, probably you can map in your mind the profile of the calls you may receive as you work on this IMA Helping Hands. Dr. Arun Kishore. I would request every one of you to mute for the smooth conduct of the sessions. And probably in the end, when you have to ask questions, you can unmute and start asking questions. Okay. Dr. Arun? Dr. Arun Kishore?
I think Arun Kishore sir just left accidentally. He may come back.
Yeah. Welcome 91 people who have shown interest. And I'm sure your contribution in the coming days is going to be very significant for making this a model for the entire country. And it is a gratifying experience that Indian Psychiatric Society Kerala branch has been associated. Probably this is one major step towards probably breaking the barrier for even professionals to seek psychiatric help without any stigma. Many times we find that even doctors have some hesitance to probably meet a psychiatrist first, probably with our effort. We may have to break that barrier. Arun Kishore?
Arun?
Arun Kishore sir login ചെയ്യുന്നുണ്ട് വൈഫൈ ജസ്റ്റ് പോയതാണ് ഇപ്പൊ ജോയിൻ ചെയ്യും.
Okay. The general outline of the training is that you will have a session on listening skills by none other than Dr. Lakshmi Vijayakumar tomorrow. Then, since this is a helpline for doctors and medical students, there may be some focus on probably the callers seeking some sort of a guidance for or solutions for their problems. So Dr. TV Anil Kumar would be doing a session on solution-focused interventions. And we have a trainer who has been doing training for various centers, suicide prevention centers in Kerala, Advocate Lito Palantigal, to do a session on dealing with loss based on the model of intervention for bereavement and grief. Because most loss situations sometimes have some sort of similarity with a grief.
നമ്മുടെ സൈഡിലുള്ള പ്രോബ്ലം
So that would be another session. And those two sessions will be after our national conference, which is to be held in Kochi from 18th to 21st. I suppose many of you would be attending the ANSIPs. And there will be a session on probably how to buy the telephone provider on the logistics of probably handling a call from a technical point of view. And there will be sessions on probably how to handle a call, and if somebody wants further help. It's largely based on a psychological first aid model, but at some point of time, since we are psychiatrists, we'll have to step out with our professional skills also. And I believe IMA is going to have a support group wherein all branches will be having a support team to assist a doctor who is going through some crisis. Probably we will have tie up with that support group also. Probably if you find that a doctor from a particular branch.
Sir, Arun Kishore logged in.
Yeah, Arun Kishore.
Hi,
Yeah.
hi, see.
Yeah, you can
Hi, sir.
start, Arun.
Good evening. Good evening.
CJ, are you asking me to start?
Yeah, sure. Without
The
wasting much
platform
time.
is for you.
Sorry.
Sorry.
There's some problem with my Wi-Fi. So I might need to show a
wife
few
anyway.
slides. I might need to show a few slides. Can I be made a co-host?
Suresh, Suresh, help him out.
Yes, sir. Please share the slides.
No, you'll need to make me co-host, Suresh. for me to share the slides?
Host is IMA, who is IMA?
No,
Kerala
it's
State
Suresh.
branch, IMA is the host.
Suresh, just bring up the person concerned at
One,
state
okay.
headquarters.
Suresh sir
But I'll-
is contacting.
Okay,
Arun,
I will.
probably you can visualize the type of calls you
I
are
will
likely to.
Don't worry. I don't need to show slides for my talk, but thank you. I will reduce my introduction so that I can go straight into my talk. Thank you, Dr. Joseph Benaben and the other IMA dignitaries for inviting me here. Suresh, it's a pleasure to be here with you, as it is with CJ, Sudarshan. And I can see several of my classmates here as well, and IPS members. So it's a pleasure to be here. What I'd like to do today is to take you through the reasons for somebody like me to be able to give this talk, as well as to share with you my insights into what happens to a doctor who presents to a emergency service. So let me start with a small story. In 2015, a patient of mine stabbed a well-known person on the road in Sussex in the UK. So I was a consultant psychiatrist in charge of the case. The patient had a diagnosis of autism, did not have any history of violence before. But because this was a respected member of the public, the case came to the national newspapers. It was reported on BBC. The trust was criticized severely, as was I as the doctor in charge. Now, what happens to a doctor in England when a patient of yours does something criminal is that you're subject to an investigation by the trust, you're subject to an investigation by the General Medical Council, the GMC, the equivalent of the IMC. You're also subject to interrogation by the press, and you're also subject to interrogation by your own colleagues. Now, the most difficult thing about this was I never knew that this person was going to do this. I had no inkling. All risk assessments had shown that he did not have a tendency to become violent. It was a one-off incident. He was not psychotic. He was seen 15 minutes later by a forensic psychiatrist who did not think that he had any problems in regards to psychosis. But you know how these things work out. So for the next 2 years, I was subject to an inquiry by the press, by the GMC, and also by my trust. Now, the major problem when you're subject to this is that you become slightly paranoid about everybody.
Sir, you can
And
share the slides.
Thank you so much, Suresh. Thank you.
Yes.
I'm going to just there's still a problem with okay. It's okay, Suresh. I think there's still a problem in sharing my slides. It doesn't matter. I will
Yes.
talk you through it. I will talk you through it. I don't think we should.
It is visible in between, but now it is gone.
No.
We had a glance of your screen.
You did? Okay. I will try once more, and then after that I will stop sharing my
think Suresh, you make him co-host. I think then probably.
Yeah, I am co-host. Sir can directly share the slides.
I am sharing it now. Can you see anything?
No, no, sir.
Your
No.
screen is seen, sir. Your screen is seen.
Yes, for some reason, it's not allowing me to share what's on my desktop. I don't know what the problem is, but don't worry. Look, I will talk you through my slides rather than wait for this to happen, okay?
Okay.
So let me go back to my story. So I was subjected to 3 years of an inquiry, at which time my practice was restricted by the General Medical Council. Now, you know what happens to a senior consultant who becomes the target of the press, the place you work at, you don't feel supported at all. I became isolated myself. I had no opportunity to talk to any of my colleagues. In fact, a couple of my colleagues were doing the inquiry themselves. It's a very difficult period. It's an extremely difficult period. And I must say that it's only because of the support from my family, from my friends, and from a few colleagues that I stopped myself from descending into depression. It's only because of their support that I stopped myself from becoming, drinking too much alcohol. And it's only because of their support that I stopped myself from leaving my profession. So, what happened after that? I was exonerated by the GMC totally, but it took 3 years for that to happen. I was in fear that I would lose my job. I must admit that I had at points of time suicidal thoughts, but never, took that forward into any actions. I think I was definitely in a low mood, though not depressed. So I joined a group, and I've trained myself in group psychotherapy. I also trained myself in balanced groups, and I joined what is now called the Practitioner Health Group. Now, the Practitioner Health Service in the UK is an organization by the National Health Service just for doctors who have emotional problems. And I've been working with them for the last 8 years. So I started in 2015, been working with them for the last 8 years. I just left that service because I have other things to do. So I will describe my experience of helping other doctors. This is the main, what shall I say, motivation behind my own desire to form Accept Support and Help Another. Because I believe if you want to help another doctor, another professional, you need to have analyzed your own feelings, your own experiences of going through a difficult period. So that's the personal story. And I'm happy for any of you to ask me about that personal story. The second bit that I'd like to talk about is what happens, or when all of you see somebody, a doctor, who presents with mental health problems, I'd like you to think of, is there actually an increase in mental illness amongst doctors? And I'd like to say that the data is conflicting. A 15-year longitudinal study showed that depression is increasing amongst UK doctors by 0.5% a year. We also know that 1% of medical students are excluded, of whom half are excluded because of mental disorders. We now know that 40% of health-related retirement is due to mental disorders. Now, what this means is that at two ends of the spectrum, when somebody joins medicine and when they are retiring, they are at increased risk of mental disorders. But we also know that 28% of doctors have above threshold stress. The last point is that suicide is 2.5 times more common amongst doctors as compared to the general population. So the question we need to ask is, if there is an increase in suicidal tendency amongst doctors, but mental disorders is not that common, then the question we need, all volunteers who are here from the IMA need to ask is, do we need to diagnose everybody who presents here with a mental disorder or not? So stress is greater, but the possibility of suicide is due to other factors. And we need to think of other factors. And to think about this, I'd like to quote a study which has been done in India back in 2018 by Sandeep Grover. Now, what Sandeep Grover did was he studied doctors at the prestigious institute, the PGI Chandigarh. And he sent out a questionnaire to all residents and to all consultants, faculty there. And he looked at the data that he received back. So he sent it out to about 1,700 people, and he got back about 30% of the people responded. One of the major factors that he found was that the working hours of a resident are about 80 hours a week, of the faculty about 53 hours. And he found a correlation between increased working hours with higher stress. And this is an important point to note, because you know that doctors spend 80% of their lives in work. They never switch off. What he also found that 30% increase in depression scores on the PHQ-9 amongst doctors. And at least about 17% of doctors answered positive to one suicidal question, that is, having a suicidal thought. When he looked at the stress scales, he found that burnout and stress was common in about 90% of them. 44% of the doctors were at risk and 17% were at high risk. So what I'd like to reiterate to all people who are present here is that it does not depend upon mental disorders, but it depends upon the working conditions of the doctor. And the working conditions of the doctor do relate to the stress that they experience. And that can push them on into depression or other mental disorders. So the workplace is common. So what I'd like you to think about with these factors is that depression is a common factor, but stress is a greater factor. You need to assess the risk, but do not be in a hurry to label or to diagnose. I'd like you to think about the doctor's life situation and to formulate what that might be. I'd like here to talk about a person called Ashik. This is an anonymized name. He's a third-year resident in surgery. He lives in India, works in India. He presented with thoughts of suicide. He had not made a suicidal attempt. He also said that he had recent problems at work. And the problem at work is, you remember that surgery is still one of the firms or one of the teams that works together. That does not happen in medicine. It does not happen in psychiatry. It happens predominantly in surgery and surgical specialties. The problem that he had at work was that he tended to miss out on certain things. For example, his boss would have asked him to write up a particular case sheet. He would not have completed it. He spent long hours at work. He worked about 10 to 11 hours a day. As a result of this, he had poor sleep. And as a result of this, he had problems in his marriage. And these long hours, 6 days a week, with Sundays spent mostly trying to complete work, led to social isolation. He was using a bit of alcohol. So when you think of Ashik, he presented as somebody who had suicidal thoughts, but his problems lay multi-pronged. There's a bit of problems at work, resulting in poor sleep, resulting in problems in his marriage and social isolation, along with alcohol use. So when you try and formulate somebody's problem, hello, can I carry on?
Yes.
Okay. So when you think of a doctor's problem when they present to you, do not just link it to suicidality or to depression, but think of all these other problems so that the doctor feels more understood. I'd like to here quote somebody called Pamela Wibley. Pamela Wibley works in the US. She has analyzed 1,373 doctors' suicidal notes, and she runs a blog. It'll be very interesting for you to visit Pamela Wibbley's blog. I'll send the slides across so that you can look at this. After having analyzed 757 doctors' suicides, she said, top-rated doctors die by suicide. Doctors develop occupationally induced post-traumatic stress disorder, anxiety, depression, and suicidality in that particular order. The problems that the doctor face are fueled by personal problems along with professional demands. So it's not just professional demands, but it's also personal problems that add on to it. When a patient dies, it hurts the doctor, and the doctor has what is called the second victim syndrome. If a surgeon loses a patient to surgery or to complications, the surgeon is equally hurt. But the public do not know this. They think that doctors do not have feelings. We know that malpractice suites kill doctors. That's my own experience. Fortunately, it did not kill me. We also know that medicine very often is some sort of an assembly line phenomenon. When she looked at 1,103 physician suicides, she found that the highest number of suicides in the US occurred amongst the surgeons, 969 of them. So we need to take care of our surgeons. Second came the anesthetists, and third came the family medicine doctors. Medical students were also quite high amongst her numbers. So we need to take care of both of our medical students, of our trainees and interns, and we need to take care of the doctors who are under greater stress, such as those who are in the front line. We know that in medicine, common human rights violation occurs. And I will call this common human rights violation because there is sleep deprivation, there is lack of food, there is sexism, and there is bullying. These are human rights violations which we need to consider when we think of why emotional problems occur in doctors. In fact, in Asha, we had a young a plastic surgery resident come to us, and you can watch her video if you visit the Asha website. She spoke about a time when she was doing her surgery undergraduate, surgery postgraduate training. She was in a firm where there were about 9 males and 4 females. Their boss was a male. The boss tended to be rather aggressive and also used to be slightly abusive to all residents, but he was so particularly to female residents. And this became a problem both for her and for her colleagues. But she was the one who was under stress because she could neither leave the specialty because of financial issues, nor could she stay. She finally left and went back home and told her parents, I do not want to continue with this. I will just be an MBBS doctor. What saved this young doctor is that her friends, her colleagues went to her home and they brought her back saying, we will protect you, we'll take care of the boss, and we'll raise a complaint. She had suicidal thoughts at that point of time, but she did not take it forward. So sexism and bullying can also be problems, and it's important to inquire about this because doctors do not tell you that they have problems. Let me ask a general question. So doctors may not have mental disorders, but yet they're subject to greater stress. Why are they vulnerable? Why are doctors different? Are they? And if they are, why is it so? Here I'd like to raise this particular concept of the medical self. When all of us joined in medical college, and if you ask any doctor today, the way they introduce themselves is to say, I am Dr. Arun Kishore. They don't say I'm Arun Kishore. They always add doctor before their names. And that is because being a doctor is a part of your identity. It's a part of yourself. And that is the medical self. And this medical self is ingrained in all of us. So imagine a situation like I was in, where there was a threat that that doctor identity would be taken away, perhaps by the GMC taking away my license, or in the other doctor's case of a doctor being delicensed. They take away your identity. And that identity, taking away that part of your identity, means that you're left totally without a sense of self. Now, doctors, in addition, have something else to their medical self. Even, in fact, if you look at doctors, you'll realize that most of them gaze at their patients over their spectacles. In fact, you can look at Sudarshan now, he'll gaze at you over his spectacles. That is called the medical gaze. That's a part of the personality. If you're on a flight and you're a doctor and they ask for a doctor, you will stand up automatically. You never don't become a doctor. Being a doctor is not something you do. Being a doctor is something you are. And because of that, doctors have certain personality traits. For example, I think a lot of us are perfectionistic, have obsessive compulsive traits. So we need to do things perfectly. And remember, medicine is not a perfect science. We tend to fail. Failure is fairly common. Uncertainty is very common. But as doctors, we think that we need to be perfect. And because of those traits, we tend to have increased responsibility and increased sense of guilt. So if you fail even slightly, what Sandeep Grover found in his study was that at least 68% of the doctors who responded said that they had made one common medical error in prescribing the week before. At least 17% of them said that they had made a serious error in their medical care. Some of them said that they had, in fact, been shouted at by their patients. 77% of doctors had verbal abuse. So all of these affect the medical self, which has a sense of perfectionism and then goes on to have guilt, at a sense of loss. We don't take failure very easily. We are vulnerable to failure. So the doctors who present to you with emotional problems may have had one, two, or many of these. In fact, the young doctor who came to us in Asha, she said that she had the sense of failure because she felt that whatever her boss said was true. She internalized it, and then she started to think that that was true. It's also important to remember that, and as a personality trait, we doctors carry what's called emotional labor. So patients tell us very difficult stories. They tell us stories about financial loss. They tell us stories about emotional problems. But we as doctors are not supposed to show our emotions. And that is a very difficult task. The emotional labor means you hear and see something as a human being, but as a professional, you're not allowed to show it. So where do you take that particular feeling? Where do you take that particular sense of emotional upset? The difficulty is that a lot of doctors don't have spaces to talk about their emotional problems. I've been to several IMA meetings, I've been to several Indian Psychiatric Society meetings. I know there that we talk about our patients there, but we don't talk about ourselves. There are times when I felt very angry towards my patients. There are times when there's a patient I did not want to see, but I've continued to see them out of a sense of responsibility. And that sense of responsibility is something which is a part of the medical self. I will not abandon my patient, however bad they treat me or however they make me feel. But where do I carry the sense of responsibility and inability to process my emotions? So let me quickly try and come back to this bit about an approach to professionals who seek help. I've spoken about the issue that there are not very mental disorders in doctors, but there is stress, and I've told you about the reasons for the stress. We spoke about the fact that there are factors within work, that there are factors outside within the family, which also lead on to stress. We've also spoken about the factors that this can lead on to features such as a low mood, depression, or anxiety. So, how do you approach somebody who approaches you? And I'll tell you how I approach them because I think that would help all of you. So, when a doctor does approach, I realize that I work in a clinic where people who come who have had suicidal thoughts, but all of you will be facing doctors who come to you feeling suicidal at this point of time. The first thing I would say is treat them as professionals, as co-professionals. Do not treat them like a patient. The moment you take on that attitude that you take towards patients, it will put the doctor off. What I mean by this is you must be friendly towards the doctor who approaches you. You're not their friend, but you must take a friendly approach. You must take an approach like another doctor who might have experienced similar feelings. So ask them about suicide risk, but please ask them only towards the end of your interview. Because if you start with suicidality, it will put them off. What I tend to do with doctors who present, for example, let me give you this young doctor who presented in the UK. He's an Indian doctor, an international medical graduate. He had just come to the UK 6 months back. He presented to the service with suicidal thoughts. So when I asked him about his problems, he started off by saying that he had come to this country, he found it very difficult to understand the system. So I let him talk about the system and I spoke about my own difficulties with understanding the system when I went to the UK around 18, 19 years back. So then we got onto a similar level where he could talk to me. And then I started to ask him about what his issue was. And you know the first thing he said? He said, my problem is that I'm going through a very difficult divorce in India with my wife. He's from the north of India. He was going through a very difficult divorce because his wife was accusing him of various things. I don't think we need to go into that. But he had the confidence to talk to me about this because I did not start by asking him about his suicidality. Then I asked him what had prompted him to seek help with the service. I said, what made you come to us now? You've had this problem with your wife now for several years. And he said that his wife had come to the UK and that she had registered a complaint with the UK police. And then I asked him what that was about. So we got into a discussion. What I'm trying to say is, most doctors who present to you would have started their crisis building up over the last few years, and they will reach crisis point. Most doctors are very reluctant to talk about their problems. Why is it? What are the biases that stop doctors from seeking help? The major bias is that we doctors don't know about how to talk about our own emotions. The second bias is that if I do tell a fellow doctor, I will be seen as being weak. I'll be seen as somebody, I'm a doctor, I should know how to solve this problem. The part of the medical self is that we think that we have immense power to understand everybody else's problem and hence to understand our own problem. We don't. So this cognitive bias, which makes us think that we can understand our own problem, stops us from seeking help. And even if we seek help, it makes us think, I must be very weak to have to seek help. That's another barrier. The third barrier is the fear that if you are diagnosed with a mental disorder, you will possibly lose your job. The fourth factor that stops doctors from asking for help is that how can I waste another doctor's time? I'm taking up their own time. Even if they're coming to a professional service, they feel that they're taking up another doctor's time. So doctors, when they approach you, are already ridden with guilt and bias about seeking help. The very fact that they sought help is a big, big ask of them. So treat them with respect. The next thing I would ask you to do is to look at safety factors. Anybody who is suicidal, I will not lecture to all of you about suicidal risk and how to assess it, but look at safety factors. What I mean by safety factors is, ask this doctor, is there somebody I can call or talk to other than you? Will you give me permission to speak to somebody else? Get that number if it is of a wife, of a colleague, or anybody else. Get that number, because sometimes doctors tend to cut the call midway if they feel offended or if they feel that they are talking too much. You can always call them back, or you can try and ensure safety by asking another person. Ensure safety factors also by making sure you have a contract with them, telling them what you can do and what you cannot do. And the last thing I would say is, help them to formulate why they reached this crisis point, why they got to this particular point where they had to seek help. And I think that's so important in the way we approach doctors. So let me try and round this off by telling you, all of you, what happened with my particular problem. Because I sit here in front of all of you 8 years later. I said the GMC exonerated me, so I was found faultless. The people in the trust who had started the investigation issued an apology, but I still have a sense of guilt. My sense of guilt comes from the fact that another person lost their lives because of my practice. And that sense of guilt is something I carry even today. It does not go away. Any doctor here who's lost a patient to suicide or to death otherwise, I'm sure you never get over it totally. You may reassure yourself to say, well, I did the best that I could, but that is for legal terms. Emotionally, you never really get over it. What really helped me in that particular period is a set of 3 colleagues who visited my home, made sure that they came and spoke to my wife. They knew that I'd told my wife. It took me 3 months to tell my wife and my daughter that there was such an issue, that there was a prospect that I might lose my job. It took me 3 months because I was ashamed, deeply, deeply ashamed. But I know that there was no reason for shame, because medicine is an uncertain science. I could not have predicted the fact that the death would happen, but I personalize it. And that personalization is what brings people to the verge of thinking that I am responsible for this, and that's what leads them on to suicide. I think I've said what I have to say. I'd be happy here to answer any questions. I think I've got another 10 minutes to go. I'd be happy to take any questions and to answer them possible. Thank you all for patiently hearing.
Yes, questions, please. No, I don't know. One thing you said, but it's customary that you should ask the suicide question last. When you deal with professionals, I think we should refrain ourselves from jumping into probably clinical diagnosis straight away. Probably we'll have to resist that temptation to probably label that person as somebody suffering from A, B, or C. And rather than the attempt has to be to make an voyage through the emotions or through the feelings the person is undergoing to whatever stress that person is having. I think after 5 minutes of talk, if you say that I think you are suffering from a major depressive disorder, I put off a doctor. perhaps not a layperson. I don't know. Like I was just adding to some of the things you have been telling, and just to stimulate discussions.
Okay.
Arun Kishore,
Yes.
glad to meet you after a long time. See you. My question is that you are mentioning about the media inquiry. What is the sort of inquiry that they are doing?
Okay, I'll answer your question in a moment. But thank you, CJ, for that issue, and I will reiterate what you said. Please don't start off by making a diagnosis. Don't be in a rush to make a diagnosis. Make a diagnosis if you have to towards the end. You mustn't diagnose a mental disorder and refer on if that is necessary. But let me tell you that in the service that I work for, 79% of the people who are present there do not have a diagnosable mental condition. We diagnose adjustment disorder, 79%. And this is over the last 15 years. So what that actually means is that diagnosable mental illness may not actually be present, but distress definitely is. So thank you, CJ, for saying that. And I also believe that if you make a diagnosis, look, the doctor would have made the diagnosis themselves. They'll come to you saying, I'm depressed. It is up to you to say that this is not major depression. It is a low mood as a result of so-and-so. So Radhakrishnan, thank you. Hello and good to see you. So your question was about, can you just remind me, Radhakrishnan? You were saying
Media
about
thing.
Media inquiry.
media.
You
Yes.
faced at that time.
Yes. So look, I'm a part of another group of group analysts who meet regularly, and we talk about, consult doctors who have had homicides through their patients. So we're a group of psychiatrists who talk about it, and we meet every month. 99% of the doctors who have had a homicide in their clinical practice are subject to intense media scrutiny. You will have the press parked outside your house. I did not, fortunately, with cameras. You will be accosted on your way to work. That happened to me. I was stopped. You will have people visiting the hospital asking for your details. I had people, go back through my history to look at things like, this doctor is from India, so how can he practice in the UK? This is something that the media asks. So the media scrutiny is intense, it is shaming, and it is sometimes, not sometimes, mostly, it is very, very dramatic, melodramatic. And that makes you feel terrible.
Sir, there is one question from Dr. Sagar. Sagar, please.
Sir, yes, sir. Good evening, sir.
Good evening. Sorry, Sagar, you're on mute.
Please unmute, Sagar.
Yeah. Sir, one important issue is with poor drug compliance, maybe more than what we observe with the normal patients, other patients, other than doctors. I had a few patients doctor, and a few of them, they do not follow the advice, they may be, reluctant to take medicine. There may be a lot of questions, that kind of issues are there. What is your, how can we get rid of this issue, sir? Thank you. How can we address this issue?
Sagar, thank you for that. Yes, doctors are reluctant to take medication, especially for psychiatric disorders. I found that in my practice that doctors are reluctant to take mood stabilizers, especially. Antipsychotics, yes, it becomes even more difficult, though I've not had to prescribe antipsychotics to very many doctors. The way I tend to get over this is I work with the doctor, getting a psychological formulation in place so that we get a linear view of their problem. Very often, And once they get the feeling that I understand their problems from different perspectives, they're willing to then start to talk to me. I'll give you another example of a patient who had ADHD. And this doctor was reluctant to take medication because they'd heard of the side effects of ADHD medication. She actually went to another consultant and then, was referred to me because I work with people with ADHD. And the issue was that the doctor said the other consultant was actually looking like my father, So I asked her, what do you mean he looked like your father? And she said, well, he behaved like my father. He told me, you must take medication, otherwise you will never improve. You'll get, thrown to the GMC. So I sat with this doctor and I said, look, fine. What is it that you want to actually achieve in your life? And then we sort of broke it down into various things. And I said, look, you don't need to take the medication every day. You take it at a time when you think you need to perform the best. But she said, oh, really? So she got this feeling that I was willing to work with her to improve her ability to function rather than treating her as a patient. So I treated her like another doctor. So we discussed the various things. We spoke about, the availability of medications and stuff like that. You need to be much more creative when you approach doctors.
Sir, there is another question by Dr. P.S. Indu. Indu, please.
Hello, sir. This is in the context of medical students. What would be an ideal balance between universal intervention and targeted intervention? In the context of universal interventions, mentoring, both horizontal mentoring and vertical mentoring. And I work in Kollam Medical College now. Horizontal mentoring is already there to some extent. First MB with first MB teachers, etc. In vertical mentoring, we are trying something like all through the 4 to 5 years, the same mentor will continue to be with the mentee. That is regarding the universal. What would be the ideal targeted intervention strategies, as whatever you mentioned about, not having a label with for doctors applies to medical students as well?
Indu, are you talking about, good to see you, Indu, and good to see Anil here as well. Indu, are you asking about mentoring in terms of general mentoring, or mentoring for people or students who have problems?
Both, sir. Universal, both. It's everyone. Targeted, both.
Yeah. So here in the UK, we have both. We have both. So universal mentoring, I think, is very important. So every student group, every batch of students are formed into groups, and they have mentors. So we have two types of mentors. One is we have senior medical students, fifth-year medical students who are level 1 mentors for, let's say, first year and second-year medical students. We also have a tutor who is, takes on a larger group. So that carries on throughout their medical career. And the students who are in their first year, when they reach their first year, their fifth year, they have the choice to become mentors themselves. And we have mentorship training. That I found is extremely useful. Extremely useful. The second bit, which is about targeted mentoring for, let's say, students with dyslexia, students who have difficulties in relationships, some people who have autistic symptoms, or some people who have difficulties in relating to others, peer relationships. There, what we found is that if you try and deal with that within the medical school, it complicates things, because if there is a legal issue, then the medical school comes into, or the medical college comes under problems. So we tend to take that out. So people who need targeted interventions, we have what we call a stepped care approach. So level 1 would be, they just need watchful observation and a little bit of support. So they get slightly extra support. If it reaches level 3 or level 4, step 3 or step 4, we take them out. And then they're part of the usual mental health system, so that they're seen by consultant psychiatrists who are independent totally from the college and the team.
Sir, there is one question in chat box. What is the best way to reduce stress?
CJ, I think you were about to answer the question yourself. Would you like to come?
No, not that. There were two questions. I thought probably you can answer them both together. How do we detect early if our colleague is getting depressed?
Okay, so one was how can we detect whether a colleague is getting depressed, and second is
the best way to reduce stress.
Oh, okay. I think that, look, I might be slightly old school, but I think what is happening today in medicine is that we are all working in silos. Even the moment you leave medical college, the moment you join in for your post-graduation, you start to become very, very independent. There are no opportunities for us to meet together. There is no common cafe. There's no place where we all eat together. There's no place where we all go out for a night together. And I'm seeing this in India and in the UK. It might be a reflection of more common sociological family issues that are happening in wider society, or it might be an issue around the increased competitiveness that happens, even before joining medical school. So people become very competitive and then they see each other as being very different. And because of this, I mean, previously, if one of my colleagues looked a little off color today, I mean, I know Shaji is my colleague and we were together in Thrissur. If Shaji looked a little off color, I would ask him, boss, everything okay today? I would have the freedom to go up and ask him about that. I don't know whether people have the freedom to do that today. So if you ask me what is the commonest sign of depression early on, I think it is the difference in the way people work. If you know them very well, it's in the difference in the way people work and appear at work every day, or absenteeism. If you find that, I think the first thing to do is to go and ask them, is everything okay? And don't feel hesitant to ask that. How do you manage stress? CJ, I'd be happy for you to add on to this. I'm sure you would have other suggestions. How do you deal with stress? I think the best method is to prevent. And here I will quote directly from CJ in the interview that he gave me. He said that he manages stress, one, by having increased activities outside being a doctor. What do you do when you're not a doctor? How do you suspend that medical self and become a non-doctor out there? How do you have people outside the profession to increase your social contacts? I think that's important because you have relationships you think outside being a doctor. The second thing I think a lot of stress comes from our own profession, which comes from things like time, increased work, increased responsibilities that you have. The issue is how and when can you start a discussion with your managers, with your colleagues about how do we manage time within ourselves. I think time management is a big stress. The big finding in the UK, and this is a paper called Caring for Doctors Who Care for Patients. It is a major UK study. The major cause for stress there was felt to be loss of autonomy for a doctor. Doctors experience the need to be autonomous, to be able to decide things for themselves, and also to consult others if they feel that they have problems. In fact, CJ said something like this. He said, if he has a difficult patient, he would ask a colleague about it, but he has the autonomy to decide what's happening with this patient. And then he can consult somebody. Doctors today lack autonomy. The question I'm asking all of you is how can you take that back and become more autonomous without having to change the system entirely? The third thing is, I would say, exercise, sleep, and diet. These three things are so important. In fact, I tell my patients with ADHD, you don't need to take medication. If you get your sleep cycle back on track, you'll be fine. If you get your diet back on track, you'll be fine. If you can exercise, you'll be fine. And maybe you can take medication occasionally. The same thing goes for doctors who are stressed. I think the important thing there is to get these three things back. And then there are lots of relaxation techniques and things which I will not go into today.
Sir, there is a comment in chat box, maybe a question also. I will anyway I will read it out. Too much competitiveness and imaginary rat race and trust issues are real problems among doctors. A change in collective outlook and attitude needs to be made among doctors. These issues are there in other professions also, but our work is more stressful. That is why also work overload. Maybe a comment.
Can I just talk 1 minute about this? In psychiatry, we have something called Ballant groups. What is the Ballant group? A Ballant group is a group of doctors. It is general practitioners, psychiatrists, physicians, all of us come together. We start off by discussing a case. It's a case discussion. It's a case-based discussion. But the discussion is not about the case. We don't talk about the patient. We talk about the doctor's reaction to the patient. We don't talk about diagnosis. We talk about the doctor's difficulty in managing this case because of hospital issues. We talk about the doctor's difficulty in managing this case because of colleagues. So the discussion is not about the case, it is around the case. I think that medicine needs spaces like this where doctors can meet to talk about non-medical issues. And that, I think, one of those is the sense of competitiveness, which I don't think the competitiveness comes because of, I think it comes because of a lack of communication. I think it comes, a lot of problems I've seen amongst doctors in the UK and in India, pardon me for saying this, is because of a lack of proper communication between two senior consultants or two senior doctors.
Arun, what do you think? What is your vision about helping hands, IMA helping hands? How it should go about from whatever you have talked? Your take on that.
CJ, my fantasy is that IMA helping hands works as initially as suicide prevention. I hope it does not stop with suicide prevention. I hope it expands into a larger body where we can, start to support doctors who have emotional problems other than suicidality. My bigger fantasy is that we start a dialogue within the medical community about these issues that we spoke about earlier. Why is it that doctors are getting assaulted by patients? Why is it that there is a sense of competitiveness? Why is it that a doctor cannot lose a patient? And what can a doctor do when they feel responsible for losing a patient? I hope that there is this ability to have a wider dialogue amongst the medical community, because there's a famous sociologist who said that, and I'm talking about death here, death happens in society. It is, you can't escape death. Even the Buddha said, show me a house where there has not been death, and I will show you paradise. So death happens, but because society feels that they can't deal with death, they pass that on to medicine, to doctors, to prevent death. We can't prevent death. We might be able to prolong it. But the fact that death occurs is seen as a disaster and as a crime in society. Where do we have the space to talk about this amongst doctors? Where do we have the space to talk about issues such as, I felt so angry towards that patient, I wish somebody else would see him? We should have spaces. And that's my last fantasy, CJ. I hope Helping Hands can expand into that. And that's the policy behind ASHA. Helping Hands and ASHA can work together.
Arun, the scope of this particular Helping Hands is emotional well-being also. We have sort of expanded it, and we have not narrowed it down to suicide prevention alone. It is the emotional well-being part of it. And IMA Kerala State has another working group on supporting doctors, wherein a support cell, where all branches would be having a team that would be supporting doctors in need of some sort of help or such things. Probably that is one. If that comes up, probably Helping Hands will have a link with that group. Probably they would be reaching out to a doctor who need also. Probably that's part of my fantasy also. If that sort of a link happens, probably that would be wonderful.
Thank you, CJ. I'd be glad to be a part of that initiative if I'm invited. Sorry.
So your fantasy has to come true, reality.
Sir, one question. Arun Krishna, sir.
Yes.
Yeah.
Sir, in UK, do you have any experience with the tele helpline or any sort of this service for doctors and medical students? Like what we are doing here, tele helpline service. Do we have there such sort of service in UK?
There are 5 organizations, Suresh. That's what I started off by saying. So I worked for Practitioner Health. Practitioner Health is a service by the National Health Service, NHS, where doctors can refer themselves if they have emotional problems. There is Doctors in Distress, which is another organization which works with doctors who have mental health problems and suicidality. There is a third organization which is called the Wounded Healer. The Wounded Healer works with again with doctors who have gone through difficulties in the court with the GMC and otherwise. So there are 5 organizations here, and I think I would be happy to link you up with all those organizations so that you can sort of try and work with each other. Because look, don't import anything from the UK to India. I think you should have a common forum just to talk about this. And also remember that there is an international, every year, and this is a meeting I go to, there is an International Association for Physician Health. And I suggest that the IMA, or some of you at least, become members of that and come to those meetings. Sorry, CJ, I interrupted you.
We have a great difficulty in dealing with a doctor who is an alcoholic or who is into substance use disorder. I mean, this is a great challenge. I mean, quite likely that the helpline may encounter a similar situation. How do we go about it?
Extremely difficult, CJ. Look, the difficulty is, I mean, if you catch the doctor early, then perhaps you might be able to help them. The difficulty here in the UK, or the easier bit in the UK, is that because of the GMC, a doctor who's reported can lose their license. And the GMC can actually say that this doctor cannot work until such and such a treatment is brought about. But that's in the UK. I don't think that can happen in India, or it may not come about. The issue, I think, is like treating any other doctor who has an addiction. And believe me, there are doctors who have serious addictions here in the UK. I've come across people who have multiple drug addictions, and we very sadly had to put them into rehabilitation and other facilities. But honestly, CJ, I don't have an easy answer for that. I don't have an easy answer. It will be like treating any other person with, let's say, a senior executive who has alcohol dependence or substance misuse. I don't have an easy answer for that. Suresh might know. He deals with them every day.
Difficult, sir. as being a doctor to treat for their substance abuse or alcoholism, I think it is a very difficult task. Very difficult to deal with those people. And especially many of these people have an underlying comorbid personality issues also. So in the same way as a friend treating a person, a doctor with a substance abuse or dependence will be a very difficult task. Then I think we have to act as a doctor and the other person should be a patient. I think we have to consider him as a patient, then only we can treat. Otherwise, it is very difficult to give them the directions, suggestions, and all. They will not agree to us otherwise. If you are dealing in the same way as professional friends, it will be difficult.
Dr. Arun? Hello. You told about the guilt for the consultant after the death or suicide of a patient. What's your personal opinion? I'm very happy in certain patients when die, actually. That too committing suicide. But you told that there is a persistent guilt in the doctor after the death. What's your opinion about this thing?
So I don't know. This might be my personality.
Yeah.
It might be entirely my personality. But I think for me, I still remember the first patient of mine who committed suicide. I still remember the last patient who committed suicide. They don't go away from my mind. You know, it's like, I don't know if any of you have read Anita Nair's book called the Last Man or something like that. Anyway, so in that there's a tormented soul, a man to whom ghosts come back. And I think my ghosts are my patients who died. But then that might be my personality. But I learn from each patient who I failed. I think I learned, and I learned so much from the patient of mine who killed somebody else. I learned how to help others. So I think that there are ways of sublimating this, but I don't think the memory ever goes away.
Any more questions?
Sir, one question is there in the chat box. Just I will read it out. How has the internet and mobile phones changed the scenario?
Practitioner scenario or physician scenario, I suppose.
Change the scenario they're asking.
Maybe the Google threads and the Google. I hope that is true, Rajalakshmi. Rajalakshmi has raised the question.
Yes.
Rajalakshmi, is that what you meant? Is it?
Can you unmute and make it a little more clearer? Rajalakshmi?
Rajalakshmi unmute. 1 second, sir. We will unmute.
Yes, sir. I would like to know how it has changed the outlook of the people, as well as how the treatment line from the doctor side also.
Did you mean specifically in terms of mental health issues, or are you asking about general
mental health issues, sir?
You mean things like internet addiction, if you want to call it?
Yes.
Is that
internet addiction, and then the infodemic? There's so much of information. So do they allow the doctor to treat them properly?
Well, Rajashmi, what I'd like to say is that
the diagnosis, and then you are left in a position where you can't get back onto your words.
Rajashmi, I don't think this is a new phenomenon, and I'll tell you why. I'm sure CJ remembers a patient who would enter the OP with a magazine under their arm, underlined with the symptoms that they think that they have, or the diagnosis that they think they have. And this is before the days of the internet. So the well-informed or so-called well-informed patient has always been there. And that has possibly changed now because of because of Google and because of the increased use of the internet. So if you're asking me, how do we approach a patient who's well informed? I think the first thing is not to feel threatened. Don't feel threatened by them, because they're coming to you with their doubts. The way I tend to approach this, and believe me, in the UK, this is even worse, because because they speak English, the patient comes and tells you, I'm depressed, doctor. Because they don't have any other language for it. They don't say, I have bejar, or I have manasinu sugalya. They say, I'm depressed and I'm anxious. And it is my task so I say, help me to understand what you mean by that. And I say, look, for me to help you, I need to understand what's going on with you. So let's talk about what exactly you feel and what you think are the reasons for that. Because believe me, look, patients make their own formulation. They have their own thoughts about why they are depressed. And sometimes it is correct. So the important thing is not to ignore it. The important thing is to acknowledge it. And the third thing is not to feel threatened by them. They're not becoming the doctor. I've had doctor colleagues who have actually taken the stethoscope out of their ears and said, "Na ningala doctor aikulu, ningala diagnose cheyacha." Or I've thrown the prescription pad at them and said, "Na ningala varudha ezhukulu." I find no reason to be threatened by people who come in like that.
Yeah, there are a flood of questions in the chat box. Suresh, yes.
Sir, there is a question from Dr. Christina. Have you ever had to help colleagues, friends who are doctors, managing boundaries, etc.?
Thank you, Christina. Hi, and good to hear from you again. Yes, so I've had, like I said, because I work for practitioner health, I see doctors, once a week. I see them every time, but then they're not people I work with. I've had people reach out to me because they know me, either because they know friends of mine or because they are relatives or doctors. So managing boundaries, I think, it is difficult. It is very, very difficult. And the most difficult thing is, I think, about the sense of boundary that you feel, because they may take the freedom. They become your colleague and they become your friend. So they take freedom sometimes and may use up your time, use up your WhatsApp, impinge on your outpatient time. How do I manage that? I think I try and manage it as sensitively as possible, because look, two things. One is, if you feel that somebody is becoming too intrusive, I think it's important to call it out and say, I'm happy to see you, but look, just as you have 100 patients sitting outside, you can see that I have about 50 sitting outside. How do you expect me to deal with this? So if the doctor is becoming very intrusive in that sense, then I tend to call it out. But the first thing I do is to try and reduce their anxiety, because people I feel who intrude on your time are the ones who are very anxious. And if anxiety is a problem, then I tend to point out that, look, we need to deal with your anxiety about this particular issue. What is your anxiety about? It might be, very often it is about that I might get thrown out of my job. And this is what I found, if I'm diagnosed to have a mental disorder. The second is, their anxiety is, what will happen to my marriage? The third anxiety is around, will I be able to function anymore? And this is the reason why they want a quick outcome. The fourth issue for me is that the doctor themselves have their own treatment plan. They come to me and say, look, in NIMHANS, there is this treatment. Why don't you refer me on there? Or they say, look, there's this particular treatment which is available in the US. Can I get it here? And so professional boundary issues becomes about knowledge. It becomes about, can I impinge on your time and things like that. It isn't easy to deal with, Christian. I don't have a quick answer to it, but I think I go
Yeah,
case by
I also wanted to I also wanted to talk about maybe our because we know the person already, and those kind of boundaries where we can't be objective. We can over identify. Even if we don't know the person just sort of reminds you of yourself, maybe 8 years ago, or I was also talking about over identification and lack of professionalism from our part also, that those sort of boundaries. The other ones you mentioned were, of course, very valid. I agree with that.
absolutely, Christian, and I'm glad you raised that. And I think over-identification becomes an equally big problem. Thank you.
There is another question. Is it appropriate to treat a doctor who is well known to you? Sherlyn doesn't treat somebody who is well known to her, but what is your take on it?
No, in fact, if there is a good friend who has a mental health problem, I would not really take them on. If they're a family friend, if they're a good friend, and our families know each other, I would support them. Look, there are two issues to this. One is, of course, you need to support them emotionally. So you're their source of emotional support. But if you become their treating doctor, then it becomes a big split. It becomes such a conflict in our own minds, which is where the issue Christina raised about over-identification comes in. And I would hesitate to do that.
There aren't any more questions. Shall we wind up? Shall I sum up and say good night? Thank you, Dr. Arun Kishore. But it's a long way because the cultural differences probably with our set of doctors and medical students may pose newer dilemmas as we go forward with the helping hands strategy. It might even end up in probably people complaining that, look, this is not what they have expected, because doctors, has their own set of expectations. And let's see how it goes. And thanks for probably giving us the opening thoughts on how to go about it. Thank you, Arun. Thank you very much.
Thank you and good night.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank you. Thank you.
Good night to all. Thank you.
Thank
you, Arun.
Thank you, sir.
Okay, bye.
Thank you, sir.
Thank you.
Thank you. Good night.
Tomorrow we have Lakshmi.
Yeah, 9 o'clock sharp.
John, sir.
ശരി ലീവ് ചെയ്തോട്ടെ.
ശരി സർ, നാളെ കാണാം.
നാളെ കാണാം. അതിന്റെ ഇടയ്ക്കൊന്ന് കാണണം, മറ്റൊന്ന് ഡിസ്കസ് ചെയ്യണമല്ലോ.
100 പേരുണ്ടായിരുന്നു.
ആ,
നല്ല അറ്റൻഡൻസ് ആണ്.
നല്ല
റെക്കോർഡ് ചെയ്തിട്ടുണ്ട്.
ആ,
ഓക്കെ സർ.
ഓക്കെ.
ഓക്കെ, ഗുഡ് നൈറ്റ്.